Jane, are we able to see all the attendees? Oh, I see the participants now. Got it. Great. Welcome everyone who's joining. I'm just going to give it a couple of minutes for others to join. We're excited to get started, but just want to give people a chance to get on. Okay, it's 1:02, so I know others are going to be joining, but I want to go ahead and get started. Welcome everyone. We have a lot to cover today, so I'm going to go ahead um, and try to introduce the speakers today, the structure, and also the health prevention study. Um, so I'm Brent Gibbons, a policy researcher for RTI International and co-lead of the Health Economics Work Group for the HEAL Prevention Study. And I'll be serving as your MC for the webinar today called The Dollars and Cents of Costing a Substance Use Prevention Program, Learnings from a Research Collaborative. So we'll be taking a deeper dive into what it takes to cost a prevention program. Next slide. So for our learning objectives today, we have three. One, to promote a deeper understanding of costing concepts and approaches for researchers and evaluators. Two, to impart knowledge on the value of costing, including the resources needed as a component of studying prevention programs. And three, to introduce common challenges and solutions with examples from the HEAL Prevention Cooperative. Next slide. So what is the HEAL Prevention Cooperative? It's part of the Helping to End Addiction long-term HEAL initiative. And so we call it the HPC, the HEAL Prevention Cooperative. And it's composed of 10 research projects and one coordinating center and is funded by NIH and specifically NIDA. The overarching aim of the HEAL Prevention Cooperative is to develop and test 10 interventions to prevent opioid misuse and opioid use disorder among young people. The collaborative nature of the HPC helps to ensure comparable methods. For example, through our health economics working group, we've developed agreed upon costing approaches that are used across projects. Next slide. So at a really basic level, all individuals start out not misusing opioids. Then at some point, some people start misusing opioids. And then for some people who misuse opioids, they go on to develop opioid use disorder. Effective prevention works by disrupting this progression and has the potential to save lives and reduce personal and societal costs. And the potential for impact is huge. Simply based on NISDA, the National Survey on Drug Use and Health from 2020, consider that 9.5 million people 12 or older had misused opioids in the past year, and 2.7 million had an opioid use disorder. Next slide. So the 10 interventions that are part of the HEAL Prevention Cooperative range in where they intersect on the care continuum. And so this figure represents the care continuum and the various points at which projects are reaching people. While one project is engaging in health promotion, most projects are either in the selective or indicated prevention space. Next slide. Okay, so to get into our topics today, I've briefly introduced the HPC, and each research project in the HPC is engaging in collecting cost data, and collectively with the coordinating center, we've developed approaches to collecting cost data and that analysis. Our esteemed speakers that follow will go into more detail on costing approaches and will show their application in the HEAL Prevention Collaborative. We have David Hutton from the University of Michigan discussing why costing is important, Diana Bowser from Boston College discussing costing concepts and approaches, Hansel Yilmazer from Ohio State University discussing cost data collection tools. And then finally, all of today's speakers will then engage in a panel discussion on common challenges and solutions in substance use prevention, facilitated by Rosanna Smart from RAND. During the panel discussion, audience members will have the chance to ask questions to the panel, and please feel free as we're going through our presentation to put in the Q&A your questions. We will have kind of ongoing responses as you put your questions in the Q&A, but we'll also save some for the final discussion. Next slide. So this is our statement of support, and it represents the 3 projects: University of Michigan, Texas Christian University, and the Ohio State University, as well as RAND UCLA, where we may be drawing some examples from for our discussion. And as well, RTI International has funding from NIDA. Next slide. And so for more information, we'll put links in the chat. You can sign up for HPC electronic mailing list or visit the Heal Prevention Initiative website. Thank you very much. I'll now pass the mic over to David Hutton to talk on the importance of costing. Next slide.
Thanks, Brent. So I'm here to start us off and just ask the question, why is costing important? So let's look at the next slide here. And really, the question is, why do we care about cost? A lot of us really care about health outcomes, and we want to, reduce substance use. We want to improve people's lives. Why should we worry about these dollars and cents? So why do we care about this? Next slide. Well, I want to start off looking at the U.S. federal budget and deficits and debt. If you look on this graph at the very top, we have an orange line and a green line, and the green line is federal revenues over the last 30, 40 years. And the orange line is spending above revenue. So it's a little deficit. And we can see tiny slivers of deficit for a while, and actually a tiny little surplus for a couple of years around the year 2000, right as Clinton's presidency ended and George Bush began. But throughout this time period, there have been a lot of deficits. And you can see the deficits have been growing bigger. And actually that red portion at the bottom is the summation of all of that deficit and interest and so forth, is the national debt. It's over $30 trillion. Now that adds up to over $100,000 per person in the United States. It's $100,000 for me, $100,000 for you, $100,000 for each of my children who are under the age of 18. Every single American, if we were to split that up, it's $100,000. That's a lot of money. So I just want to set the stage here that the federal government, is spending a lot of money and incurring a lot of debt on our behalf. Well, why do we care about the federal budget here? So let's move on to the next slide. So what does health have to do with all this wonky, federal budget stuff? Well, let's move on to the next slide and see how the federal government is involved in healthcare spending. And actually, about almost 30% of the federal government's budget is on health. And so if we look at fiscal year 2023, about 29% of it, that's the area highlighted as health spending in the first little donut. A lot of that is Medicare. Over $800 billion spent on Medicare, over $600 billion spent on Medicare and Children's Health Insurance Program. We've got a lot of, many, many billions of dollars, again, almost a third of the federal budget spent on health spending. So health is a big part of this spending. A little donut on the right shows that outline on health programs. The green bar is what's called mandatory, and the orange little section is what's called discretionary. So let's dig into those next. So let's move on to the next slide. So what is this mandatory spending? Let's move on to the next slide here. And really, a lot of that is Medicare. So we saw Medicare, again, over $800 billion. That's a lot of money, even for the federal government, right? This is a lot of spending spent on health, on Medicare. Medicaid, also a really important program a lot of us care about. Both of those programs are programs that a lot of Americans rely on, but it's a lot of spending. It's a lot of spending, and we need to be, I would argue, need to be judicious about spending these resources here. So this is a mandatory spending. A lot of us probably don't want to cut this. Let's move on to the next slide. And maybe we can cut discretionary health spending. Maybe that's something where the federal government isn't perfect at spending money. Maybe there's some waste here. So let's look at the next slide here for discretionary health spending. A lot of us care about veterans, and the big orange slice here is veterans spending. We spend a lot of money on veterans health spending. That's probably an important thing we ought to be spending money on. This webinar, all of us, the speakers, and many of you are probably funded by the National Institute of Health. That's also important. A lot of us probably feel is important health spending as well. NIH budget is that big green portion here. Also, really important things are the other segments. I get a lot of funding from the CDC. I think the things that the CDC does are important. Global health, FDA, things like that are all part of this health spending. So a lot of what the federal government spends money on is health spending. Let's move on to the next slide. So here's another picture of federal healthcare spending here, showing hospital care is a big part of healthcare spending. That's the big blue pie chunk at the bottom of the bigger pie. Physician and clinical services, again, that's something we think is important, paying doctors to take care of us when we're sick, and nurses and so forth. Prescription drugs, a lot of us need the prescription drugs, and they're very important for our health. These are a lot of really important things that we spend healthcare spending on. But I would point out here, I would encourage you for a moment to think about this and ask yourself, where is substance use prevention? And I guess I would argue that it's in here. It's not really highlighted, but there's not a lot of emphasis on substance use prevention, or really prevention in general, in at least the federal budget, and I would argue also state and local and other budgets. It's hard to find prevention in these budgets. A lot of the spending that we spend money on is really taking care of people once they get sick, once they're ill, once they're suffering from substance use disorder, for example. So I guess I would argue, maybe we don't spend enough money on some of these important things like substance use prevention. I will also mention that sometimes substance use prevention doesn't even show up in healthcare spending. It shows up in other budgets, but again, very small fractions. Let's move on to the next slide. So I guess, and I will say that was just federal spending we looked at, but there's also a lot of state spending on health. There's a lot of local spending on health. There's a lot of private spending on health, insurance companies and so forth. But with that said, there is not very much spent on prevention, and there's not very much spent on substance use prevention. But what I'd argue is, a lot of us think that that's something maybe we ought to invest more in. And in the end, though, if you want to invest more in this, you have to think about costs. Costs are really important. And organizations, of course, need resources to do what they're going to do. And costing is simply measuring that resource use. In many organizations, face budget and resource pressures. You've heard things about federal shutdowns. A lot of those things are arguing over the budget. Many states face balanced budget constraints. Local governments are always strapped for cash, and non-governmental organizations, whether they be for-profit, non-for-profit, they don't have unlimited resources. So they really need to track the resources that they're using. And that's why I think part of this, what we're doing with costing, is really important. Let's move on to the next slide. And I would like to argue that economic analysis can be really helpful. A lot of us are studying interventions that we think are really, really valuable. And economic analysis can help answer important questions like, should we invest in a new intervention? If we have a new intervention that we think is good, an economic analysis can tell us if that new intervention is worth investing in. If you have scarce resources, should we spend them on this new intervention? And also, if we think it's a valuable intervention to invest in, economic analysis can help us plan for that. So if you really want to roll out a new intervention, we need to know, how much will it cost? How much do I need to budget and plan for to start this program up, to get it off the ground and running in the next year or two? And actually, in the long run, to keep it running, how many resources do I need to keep that program going and continuing to go and be successful and help people? Let's move on to the next slide. I would also argue that it's not really a given that prevention saves money. A lot of us are very interested in prevention, but there was a study done a little over a decade ago that's looked at cost effectiveness studies and looked at prevention studies and treatment for existing conditions. This graph here shows us the cost effectiveness ratios, but I want to really highlight, and we're not going to get into details of that, what I really want to highlight is the far left bars on this graph here. It shows the proportion of studies in the literature that showed an intervention was cost saving. And it looks like, prevention is maybe a little bit more likely to be cost saving than treatments for existing conditions. But either way, both of those types of things, preventive measures and treatments for existing conditions, maybe less than 20% of them are actually going to be saving money. A lot of us would love for our new interventions to actually save money overall, but actually that's not necessarily the case. So it's not a given that your prevention intervention, that any prevention intervention is going to be saving money. And that's why we need to rigorously study these to understand, are they going to save money or not? And actually, we'll hear this a little bit later, even if something doesn't save money, though, we still might want to invest in it if it improves health enough. But the economic analysis can help us understand that more precisely. Let's move on to the next slide. So I want to just highlight here that costing is essential to evaluating your prevention intervention. We're researching these interventions to improve population health, but in order to actually improve real-world population health, we have to implement these good interventions in the real world. And the only way to convince people, or one of the important ways to convince people to actually implement these things, is to not only look at the intervention's efficacy, but understand what is the economic impact of it, how much is it going to cost for us to do these things. And I think that can be really compelling to decision makers. My experience, it's really compelling to decision makers if you can show them the economic argument that this isn't going to be too expensive, and then it actually will show benefits down the line. Let's move on to the next slide. So what are we doing with the HEAL Prevention Cooperative? Well, we're supporting economic analysis of substance use prevention interventions. We're sharing best practices. We'll hear more from Diana about costing approaches. We're trying to, and how do we structure our costs? How do we collect our costs? And we're trying to understand some common themes about what do the costs look like for a lot of these kinds of prevention interventions. I will say costing can be challenging. Oftentimes with these types of interventions, we don't have really good insurance claims data, for example. We can't just grab a big insurance claim data set to understand the costs of substance use prevention. Oftentimes we have to find those costs and collect them from the ground up to really understand the cost and economic benefits of these types of interventions. And so hear more from the rest of our speakers here about some of those details. And so thank you very much, and I'll pass it on next to Diana.
Great, thank you so much. You can go to the next slide. Great presentation, and I'm going to follow on now talking in a little more detail on costing concepts and approaches. Go ahead. So this is what I'm going to talk about just for the next 10 to 15 minutes or so. I'm just going to outline a number of questions that as health economists we are asked all the time, and then link those to some common costing approaches that we use. I'll go over some details on costing concepts for data collection, and then I'll share just in the end a few quick examples, one from one of the research projects that I'm working with, Texas Christian University, on costing analysis that we did alongside their intervention. And I'll follow up with some other costing concepts, cost effectiveness analysis, and budget impact analysis. Go ahead. Okay, so as health economists, I think that we're asked questions like these all the time. And these are really good questions. We do need to know the answers to all these questions. For example, we're asked, how much does it cost for me to implement my program? Or, which program should I choose to implement given my budget constraint? Or, I'm going to be implementing the program. What is my return on this investment? What is the bang for the buck? So go ahead to the next slide. Once we're asked these questions, as you can see in the next slide, as health economists, we go back to the methods and try to match these questions to kind of standard methods that we might use in order to help answer these particular questions. And you can see here that first question, how much does my study cost? Well, that's just a costing study, and you might get an outcome like total cost or cost per unit that you could use to estimate what that might cost in the future. If you're trying to compare between different programs, you might want to use a cost effectiveness analysis that then looks at the costs per a unit of outcome. Sometimes we use disability adjusted life years or quality adjusted life years. And then analysis that I really like is what is the return on that investment? And I think those studies are really important when you think about prevention, because the dollar return on that investment might be even outside of the healthcare system. So I think it's important to capture that. Regardless of the questions that were asked and the methods that we use, the base for all of these analyses are really good cost data collection. And as David mentioned, that can be hard to do. So we're going to talk now about some standard concepts and approaches that we use. And on the right-hand side, you can see that it's all about precision. You want to make sure that you're actually capturing the correct data so you make good estimates on the costing. I'll go through some standard top-down and bottom-up techniques that you can use. And then you also want to take into consideration the perspective. Many of us use healthcare perspective, but I'll show you in a few slides that you may want to use a broader perspective as well. And all of these perspectives are important to help you figure out where you're going to get your data that you're going to use in your analysis and where you're going to target some other results for those data that you collect. Okay, go ahead. Okay, so I'll just talk about some standard cost data collection methods. They're sort of grouped in two broad categories. Sometimes they're called either top-down or bottom-up approaches, and I'll give you some examples in the next slides. Go ahead. So these top-down approaches are really using kind of overall budgets or expenditures or administrative data from a larger unit, for example, a hospital or a facility or a community or state, and then calculating the cost for the specific units that you're interested in analyzing in your costing study. So you may want to know what it costs to treat a certain type of patient or a certain staff or service in your unit. And then you can use these unit costs to then analyze further how much that might cost if you're expanding out those particular units. So for example, in your unit, you may want to set the cost for a particular service, cost per vaccination or some other service. And you could use historical data from your unit or even from another hospital or facility to calculate that unit cost in a top-down manner and use that to calculate costs going ahead for that particular unit. Go ahead to the next slide. If you don't have a lot of administrative data, you might need to do more bottom-up approaches, which is a little bit more time-consuming. But these bottom-up approaches use data on types of quantities and inputs and activities, and then you do just that. You aggregate all of the costs for those activities up to come up with a total cost for the entire process. As you can see, the first type is process costing. Another type of bottom-up method that I'm not going to talk about is time-driven activity-based costing. What I am going to talk a little bit about is activity-based costing. This is sort of the bottom-up method that I'm most familiar with, and all of the research projects within this particular healing prevention cooperative are using bottom-up ABC costing, and this is where costs are aggregated based on activities defined and resources associated with each activity. Okay, go ahead to the next slide, please. The perspective that you choose is extremely important, and you need to choose a perspective when you're doing any type of costing study. This slide is taken from the second panel on cost effectiveness analysis, which is a good resource to utilize if you're going to be doing any of these studies. And as David mentioned, most of us, since we're working in the healthcare field and that's where our data normally come from, we use that healthcare perspective, which are sort of formal healthcare costs that are allocated to these particular services, and we're trying to capture those costs for the healthcare system. However, the panel on cost-effective analysis is suggesting also that we begin to broaden these analyses to also more sort of societal perspective, which takes into consideration not only formal healthcare costs, but also informal healthcare costs, and I'll talk about a few of these in the next few slides, as well as non-healthcare sector costs. And I think these are really important as we begin to consider the broader impact from prevention activities on some of these non-healthcare sectors. And you can see those listed here in the slide. Okay, go ahead. Let me just talk for a few more minutes just on some of the details of these costing studies, and I'll just go over some types of costs that you need to include in your costing studies when you're doing these. Here you can see the main two types of costs that we always include in any of our costing studies are broken down into direct costs and indirect costs. Most of the studies that I've conducted, the major driver of these costs are the direct labor costs. And so those are really important to capture. And I think Tanzel is going to give us some examples of how we can go about doing that in our studies. You also want to include any recurrent costs on top of those labor costs, such as supplies, training, materials, and any capital items, things that you might be purchasing, computers, cell phones, tablets, etc., that can be amortized over the life of those items. On top of that, you want to make sure that you're including any fringe and other administrative costs that might not be included in your direct costs. Go to the next slide. As economists, we also like to include opportunity cost. The definition of this is right here in the slide, and it's just the cost of giving something up to get something else. And so many of the costs that we include in our studies are capturing the time investment for individuals that are working in our studies or in our interventions, who it may be difficult to capture their time investment in terms of a salary. So think of a caregiver that might be working and helping out someone in their family that may not be paid, or youth that are involved in our studies. We like to capture these costs in our studies as well, and you can sometimes proxy these with minimum wage. Finally, you can also think of these types of costs in terms of fixed and variable costs. A lot of our labor costs are fixed, and then you can add variable costs on top of that. Often those variable costs are linked with individual units, individuals that are participating in our studies, or other supplies that you might want to add on. Okay, so let me just finish up just talking about an example using this activity-based costing method, which I've already explained, which is this bottom-up method that takes into consideration all of your resources and activities in your project, and then assigns them a price weight to that activity. So you can see here in the middle, once you have defined all of your resources, for example, you may have staff that are working in training and implementation. Those would be assigned an hourly wage, depending on how long and how many hours they're working. Other intervention materials and manuals should also be included, and you'll have a cost for those. And all of those are aggregated up to the total cost of your activity. And like I said before, taking into consideration the appropriate perspective that you're using as well. Go ahead. Have been very fortunate to work alongside a wonderful intervention that's captured here in this slide, and I'm not going to go into lots of details on the study design itself, except that we were working in the setting of juvenile justice settings. And the study here, as you can see, was trying to prevent opioid use among justice-involved youth as they transitioned from the secure setting to the community setting. And they used an evidence-based practice called trust-based relational intervention. And using all the methods that I've talked about in this presentation, we have been able to cost out the implementation of that intervention along all of the different arms that you can see in this study, where some parts of the intervention use training for TBRI only, some use the TBRI training plus structured coaching, and some units in that intervention use the TBRI plus responsive coaching. Go to the next slide. And as part of that analysis, we were not only able to cost out the intervention, the actual delivery of the TBRI intervention, you can see in the middle of this slide, but also we were also able to use activity-based costing to cost out the startup cost as well. And we're also thinking about how we can cost the sustainability, which you see on the right-hand side, which is really the transfer of that program to the agency staff when the research project is finished. Go ahead. So I'll just finish up talking about two other sort of standard methods that we use in addition to costing studies. Once you've collected all of your cost information, there's other methods that you can use. For example, you can use a cost-effective analysis, which assesses the differential costs and outcomes associated with more than one intervention or arm of your intervention. And some of the standard outcomes that we might use in these studies are quality adjusted life years or lives saved, or other effectiveness outcomes depending on the type of intervention that you're delivering, such as healthcare utilization or access to care or other services. For these studies, we calculate a standard ratio called the incremental cost effectiveness ratio, the ICER, and that is just looking at the differential in costs between your different interventions, either intervention and control or your different arms, comparing that to your outcome measures, your effectiveness measures. Go to the next slide. And then finally, I think these analyses are really important as we begin to think about sustainability and especially scale up. These budget impact analyses, sometimes called BIA, are analyses that you can use to assess the impact of scaling up an intervention after you've done the costing analysis to understand the impact on costs as well as health impacts. And these are really important. I think this is really important for prevention as we begin to scale up, because as David mentioned, we're spending a lot of money and these budgets are tight. So we want evidence to make sure that when we scale up, we have the budget to do that, but there's going to be great health outcomes as well. It helps with budget and resource planning and addresses kind of the financial stream and consequences related to affordability of our prevention projects, which I think is essential to think about as we begin to think about incorporating prevention into some of our standard healthcare activities. So thank you so much. I'm going to hand over to Tanzil now to talk a little bit more about what it's like to work on these costing studies.
Thank you, Diana. So next slide. I will talk about understanding collection tools for cost data. Next slide, please. So reliable cost data is crucial for economic evaluation of interventions. So as Diana described, costing methods in economic evaluations generally fall on a spectrum between top-down cross-costing approach to bottom-up micro-costing. And the choice of method determines the cost estimates and may change the results of an economic evaluation. Micro-costing, which is also a foundational principle of activity-based costing, involves a direct elimination of each input and costing. Next slide, please. Here are some common data collection tools for activity-based costing. Right now, I will just read the list, and on the next slide, I will go into more detail of these cost data collection tools. Standardized comprehensive templates, targeted questionnaires, activity logs, on-site administrative databases, direct observation are some tools are commonly used in the literature. Of course, the goal is of these tools is to produce good quality cost estimates to inform resource allocation decisions. Next slide, please. So on the left, you see the tools that previously I just read from the list, and then in this table in the middle is a brief description, and then the common modes to collect the data, the cost data. Standardized comprehensive templates are complete templates used to collect resource quantity and unit cost data for most or all aspects of intervention. For example, a well-known publicly available template in substance use field is DATCAP. Targeted questionnaires are similar to standardized comprehensive templates, but are more limited in scope. For example, a questionnaire could be created to survey intervention staff in order to estimate the amount of time they spend for intervention activities. Activity logs are most often used by intervention staff to record their time spent on intervention-related activities. And financial records are some example cost accounting data are some examples of on-site databases. And finally, direct observation involves researchers prospectively recording intervention resource use through in-person observation of the intervention. Next slide, please. Now I will describe the cost data collection methods we have utilized in a NIDA-funded intervention with youth experiencing homelessness. The title of our study is Prevention of Opioid Use Disorder, the Home, Housing, Opportunities, Motivation, and Engagement Randomized Trial. The MPIs on this project are Natasha Sleznik from Ohio State University and Kelly Kelleher from a Nationwide Children's Hospital. And I'm the lead economist responsible for cost data collection. Next slide, please. In this randomized trial, 240 youth experiencing homelessness were randomly assigned to two conditions: either rapid rehousing, which provided 6 months of rent and utilities plus risk prevention services, or the control group, the half of the youth were assigned to risk prevention services. And the trial lasted from June 2020 to September 2023. Next slide, please. On this project, Ohio State and the Nationwide Children's Hospital teams worked together. At Ohio State, the research assistants were responsible for recruiting landlords, and the advocates recruited youth, located them into the housing, and provided risk prevention services. And the Nationwide Children's Hospital set up the accounts to pay landlords and the utilities, and completed monthly rent payment transactions. Next slide, please. Here is a summary of the inputs that were used in this intervention. So there is the labor cost, which was mostly the time of the advocates, graduate assistants, and administrative support program manager. The capital included the rent and utilities and other housing-related costs for rapid rehousing of youth, and equipment involved computers, phones. Also, there was time of consultants providing the training to the advocates and education supplies, and mileage and other materials and office supplies. Next, please. In this trial, we utilized 3 out of 5 tools that I previously described. From Nationwide Children's Hospital financial records, we calculated cost of housing, and using the activity logs at Ohio State University, we calculated the personnel time allocated to intervention activities such as time spent for training, management, acquisition of the program manager and coordinator, etc. And again, from activity logs at Ohio State University, we calculated the personnel time allocated to meetings and supervision. And finally, we created a targeted questionnaire where after each interaction with the youth, the advocates responded to up to 12 questions about their interactions with the youth. Next slide, please. So in summary, as you can see, numerous data collection tools are available, and it is important to consider the size and the scale of the intervention, setting, time horizon of the intervention, as well as the purpose of the study when the investigators decide on which tool or tools to use for cost data collection. And the important concern is, of course, the balance between required precision of the cost data and acceptability level of research burden. Ideally, investigators should have the infrastructure for cost data collection ready before the intervention, and investigators should aim to collect cost data prospectively during the study. This means the project resources needed for collection of cost data and the approaches that best fit with the project resources should be identified before the beginning of the study. Next slide, please. That's all I have, but I'm happy to answer any questions in the discussion period, so I will pass the mic to Rosanna now.
Great. Thank you so much, Cancel, and thank you to all our presenters. I think we can put the slides down at this stage. So we now have 20 minutes to engage with our presenters in a discussion of some of the common challenges and potential solutions that arise when costing a prevention program. And we can also follow up on any audience questions, but please feel free to put questions in the Q&A now or while we're talking, and I'll reference back to those. I think it's been a relatively quiet audience, so anybody, don't be shy. Please put any questions you want in there, and we'll be able to address them in this panel discussion. I will start us off because, Tansel, I'm going to start with you. It really strikes me from your research project, there were a lot of actors involved and a lot of moving parts. And I'd like to give you an opportunity to kind of help us all who may be a little intimidated by embarking on one of these costing studies to discuss any lessons you learned about how to get buy-in from partners who may have more or less familiarity with kind of tracking their time and resources to ensure you're getting accurate information from them, but not overly burdening them. So talking a bit more about this trade-off between accurate and detailed information and burden. And I'd also wonder whether you have any lessons you could speak to about whether your approach or your considerations really differed by the type of setting or the type of staff who you were interested in getting activity data from.
Thank you. So I must acknowledge first that our study had only one site, so that was our we were lucky in that sense, and these two partners were involved from the very beginning. So I think again that brings us even in the grant writing stage, how we would try to collect cost data was always in our minds. Even that was the case, of course, that we had to do some minor adjustments. And then one thing, for example, I thought that would work wonderfully, the questionnaire, the targeted questionnaire. And there was a little bit, complaint from the our advocates about the time it takes them to, after each interaction, to fill out those questions. And then once they do the questionnaire, they also it disappears. So in the follow-up study with youth, we will turn into, for example, to activity logs where they keep seeing what they have done in front of them. So when they fill out, these things will not disappear. So in the sense that the infrastructure is very important. And, at OSU and nationwide, we had the infrastructure, but I totally understand, this prevention interventions are usually, conducted in community settings where the infrastructure is not complete. But it is, the researchers should be, or multiple sites might be involved. So I think the idea here is from the beginning of the study to be clear, and then what the needs are, and also providing the infrastructure. It can be the Excel templates, etc., to the providers, so that there is like a equal burden on everyone.
Got it. Thank you. Diana or David, I didn't know if you wanted to add on anything based on your experience about potential challenges or approaches you've used in trying to balance this idea of detailed and accurate cost collection with the burden on the implementers.
I mean, I guess I'll just quickly say, doing these economic analyses in some ways is a question of cost effectiveness. How much time and effort should we spend in the economic analysis? And I think if your partners are a really big part of your program, then I think it might make more sense to invest more time in collecting that data more accurately. If your partners you think are only 5% of your overall costs, then maybe you don't have to be as rigorous in collecting that cost information. And you need to be, thoughtful about, how much depth you, and effort you spend in collecting that information. The type of work we're doing, part of it is art and part of it is science. Science, 1 + 1 is 2. That's the science of this. Numbers have to add up. But the art is deciding how much time and effort do we want to spend, collecting it, which types of data do we want to collect. So that's kind of the art to this.
Dana?
Yeah, I'll just add with the research project that I was working on, we had a number of different sites and they actually spanned 2 different states. And there was already a lot of burden on the research project in terms of implementing the study. So we were very understanding in terms of not adding additional burden. I think the important thing to understand is that a lot of these implementers are already collecting fidelity measures anyway alongside their project. So what we tried to do is tie in as much as possible to their data collection that they were already doing, and making sure that if we needed to add anything additional, track any meetings or who was attending those meetings, it was as much as possible aligned with what they were already doing, not to add that additional burden. And then I would say the most important thing is to do this alongside the implementation. I've done these studies in many ways. The easiest way is to do it, start at the beginning and work with your partners to collect this data. Other times I've tried to go back and collect data retrospectively, and that's a lot harder.
Yeah, I feel like I'm hearing from this things that echo with my own experience. Like, one is try to focus your attention more on those areas where you think the costs are going to be a substantive share of what drives your program implementation. Trying to leverage existing infrastructure and existing kind of work patterns in a way that can reduce kind of this additional burden. And then Tansil, one thing that really resonated with me, and it goes to this working alongside your implementers, is continuing to monitor and adjust. So I found before, like, oh, I have this brilliant idea for how I'll collect this cost data. And nope, turns out that was a horrible idea. And, you monitor and you're like, oh no, no one's filling this out or no one's keeping track. And you really want to work with your implementers to understand why, and then course correct. You're always going to have to be kind of willing to course correct as you go through this. So that really all resonates with me. One thing that's come up here that I'm curious as to everybody's thoughts, but for the sake of assignment, I'll give it to David, is we've talked a lot about kind of the importance of building in the cost analysis or thinking through the cost analysis from the onset of the study. And I'd just be curious, David, whether, sometimes maybe that's not possible. Sometimes maybe you're already partway through a project. When you've decided or realized you want to do this cost data collection. I actually think one of the unique aspects of the HPC has been this kind of proactive thinking around the economic analysis component. That's not always the case. So I'm curious if you could give some insights on different considerations for having a cost analysis component ideated from the very beginning of a project versus further along the line.
Yeah, thanks. So ideally, we'd be involved at the beginning to help understand how do we collect this data. And as Diana said, it's a lot easier to collect the data if you're proactive about it and know what you're looking for and are collecting that along the way. It is more challenging to estimate costs when you have to do it retrospectively. And it's year 3 of a 3-year project. And then someone says, let's do a cost analysis. And now we've got to kind of go back and talk to people. Maybe some people left, they moved to a different company. It's hard to ask them, how much time did you spend on this? And look through records, how much did you spend on iPads for this project? So it's a lot easier to start off proactively with it, but it can be done if you have to do it retrospectively and go backwards. But it is more difficult. It is more challenging if you have to do it later on. I will say also one other thing kind of for budgeting purposes, typically, even though you have to involve, it's good, I think, to involve the economists at the beginning of your project. Typically, we're not too burdensome at the beginning. We're just helping you plan for the data collection. Most of our effort, if it's in a project, is usually at the end, I think, actually doing the analysis, calculating all those numbers and so forth. And we're just kind of in the background or a little bit helpful in designing the cost collection at the beginning. But typically, if you're planning a big research grant, typically the economists aren't going to be too expensive at the beginning.
Great. Diana or Tansil, did you want to add anything to that? We also have a question from the audience that I can go to if you don't. Great, thank you, David. So we have a question from the audience that Diana, I believe I'll start with you on this because it's about, you mentioned using the minimum wage as an opportunity cost. And they ask, if you had average salaries for an applicable position in a study, wouldn't you use that? Is there a reason you would use the minimum wage? Was this specific to a study in which the individuals would only have the opportunity to earn the minimum?
Yeah, for the particular example that I was giving, we're working with youths in the justice system that are transitioning home. And many of them were not working at the time, but we wanted to be able to capture their time investment in the intervention itself. So in that particular case, we did use minimum wage. For caregivers, yeah, you could be a little bit more creative. You know, sometimes you do have equivalent salary information for caregivers, even though they're not working, or even if they are working. Yeah, so you can use other proxies. You just need to justify the use of those proxies. That's a good question. But I will give a shout out to the opportunity costs, and we've found in our study that it's, those can be quite significant. And I think there's new work on caregivers too, not just in the substance use setting, but in many settings. And I think it's really important to capture those costs from the economic standpoint.
Great, thank you. Tansel, David, anything you would want to add to that?
I can also echo Diana about using the minimum wage. We have another study where we are looking at a subgroup of young mothers experiencing homelessness. And for that, we used their opportunity cost while they are receiving this risk prevention services. We turned it into a monetary value, because that is also important when you're thinking about, okay, we have this wonderful services, but no one is using it, like in another setting. And I think in that sense, kind of thinking about the opportunity cost to the mother, foregone wages, that would be an interesting aspect to the cost.
Yeah, and I think if I can, I'll put a link in the chat here with there's a really nice study done a few years ago that looks at productivity costs, and it includes your wages, but it also includes and economic productivity outside of your wages as well. So if you're mowing the lawn or cooking dinner or cleaning your house, I mean, that is economic productivity too. So they've got some nice estimates of productivity by various ages, and so that's another potential source using for that opportunity cost as well.
Great, and I'll just add, since I can do so, I'm moderator, that I actually have found this to be a little challenging to think through, particularly in the youth setting, because often these individuals aren't employed. So it's unclear what their occupation would be. It's unclear whether one should use the minimum wage. And so in trying to think through the opportunity cost, it's like, well, what would they be doing with their time if they were not engaged in this intervention? And often that's leisure. And I feel like valuing leisure is still kind of an open question. We usually try to figure out what the employment would be. So I think this can get really complicated in different settings, but the idea is thinking through these opportunity costs in the way of like, what would they be doing with their time otherwise? And how do we account for those costs in that sense? Okay, I think we have time for one more question, and I'm going to ask maybe one that keeps me up at night, at least. So we are all kind of involved in research projects and costing on the research project side. Diana, I'm going to direct this to you because I think this touches on a bit of what you were getting at with sustainability and scale up. My question is, how do we take this costing evidence that we've rigorously collected from like a research study that is its own kind of unique beast, and think about how are those costs generalizable to implementing this in the real world?
Yeah, thank you. I think this is a really good question and a good one that we can end on. And I think as Rosanna mentioned, this was really a wonderful project because we had health economists across all research projects, and we were able to come together every month as part of the Health Economics Working Group. We called ourselves the HUG. We talked about all of these sort of methodological questions. We spent a lot of time sort of talking about how can we ensure that the costing that we're doing, because this is part of a large research project, we wanted to make sure that the costing that we were doing for all of our studies that were being implemented was really capturing the implementation itself and not the actual research activities. So we wanted to separate those out. So I think that's really important if you are working within a research study. You want to make sure that you're capturing the cost of the implementation and not the research, which you could, I guess, calculate that separately if you wanted to, but we decided not to do that. And then what we also did in our study, once we had those implementation costs, we were also able to calculate, well, and remember, we are working in this justice setting. So which of these costs, labor and other, are currently funded by individuals working in the justice setting? And which of those costs would the justice setting have to absorb once the research project is over, and they'll have to implement this trust-based relational intervention on their own. And like I said, we had 13 different sites and they all did this a little bit differently, but there was a certain percentage and actually an amount that they would have to begin to think about and plan ahead. These are either people that they would have to hire, or they'd have to reallocate some tasks to those that are working in the justice site in order to implement this trust-based relational intervention on their own. So we don't have an answer to that question yet because they're beginning to think about how they're going to make this sustainable. But the great thing is that we have the data. We now know for every site what do they need to begin to plan in order to make these projects sustainable. And they do want to make them sustainable because they've found great results with the TBRI. So we actually have an article that's coming out, and you can actually look at those costs. And we have broken them out in terms of, you know, what are the costs that are currently embedded in the system and what are those costs that they might need to absorb. And I think those are really important methods that we need to think about moving ahead, especially for prevention, which is currently not paid for in most of our healthcare settings. Screening is, but many of our prevention programs, the funding isn't really linked to kind of billable types of services. We have to think creatively about how to make those sustainable as we move ahead.
Rosanna, I think I'll take it from here. It's 1:58, so I want to be mindful of everyone's time. This has been a really engaging panel discussion. Thank you all so much. And thank you for all who attended today. This hopefully has been a fun and engaging hour, and we hope to leave you with enthusiasm for incorporating costing into your prevention research. We placed a link in the chat to provide feedback. We also have the QR code now on the screen. The RTI team will follow up with each of you with the link to NIDA's website. So that came up in comments where slides and recording can be accessed. And so at this point, we'll leave the screen up for a couple minutes to let you access the survey. But we want to thank you again, and it is Friday, so we hope you have a great rest of your afternoon and weekend. So thank you all so much. All right. Well, thanks everyone again. And thank you, Tanzil, Rosanna, Diana, and David. All right, take care, everyone.
Thanks.